everybody to the first and inaugural SAM webinar. We've put these webinars together because, as I'm sure most people who are on the call are aware, that our conferences have been seriously curtailed by the coronavirus. So if anybody wants to play COVID bingo, you can start now. I played it quite successfully in a meeting yesterday. So I'm going to start by saying these are unprecedented times that we're finding ourselves in, and we need to find new ways to communicate and new ways to learn. And this is what this is about. I'm incredibly grateful to our first sets of speakers and our people who are doing their sort of short oral presentations of their posters, which I'm sure could be pretty nerve-wracking. But welcome to all our speakers, and thank you so much for doing this for us, especially given it's the first one. I hope that everybody can forgive us if the technology gets a little bit clunky. It's our first time using it. So we're braving it, and give us a bit of slack if it all goes wrong. So you can see that we've now got the agenda up. I'm not going to run through it particularly, but I would like to draw your attention to how you ask a question. So if you go to the bottom of your bar, you should see a question and answer section. You can submit your questions there, and you can also give a thumbs up to a question that you think is particularly valuable. And we might, if we get lots and lots of questions, what we might try and do is go through all the questions that seem to be the most popular. So just have a quick read of that and make sure you know how you submit your questions. So before we start and go to Darren, who's going to give our first presentation, we'd just like you to complete a quick poll, please. So I'll give you a few seconds to do that now in awkward silence. So without further ado, I'd like to introduce you to our first speaker, Darren Green. Darren is our research lead, and he's going to talk to us about early COVID learning from an AKI point of view. Over to you, Darren.
Yeah, thank you, Sue. So I'm part acute physician, I'm part nephrologist. For this talk, I'm going to concentrate very much on AKI from the point of view of how we manage patients as acute physicians at the front door. It's mostly going to be a broad overview with a few details, but in the interest of time, I'll stick to the broad concepts more than anything else. And if you could, that's it. All right. Sorry, I've not got my. Here we go. Right. So I'll start by going through the epidemiology of AKI, specifically in acute medical patients. Then I'll talk a little bit about the pathophysiology of AKI and COVID, perhaps how it differs from other conditions, and then we'll talk about the assessment and management of these patients. And I have added a slide on the end which contains some hyperlinks to further reading, which I didn't know whether we'd be able to share these slides, but if we can't, I'm sure I can email them across to people. So to start, if you look at the epidemiology of AKI in COVID patients, reports vary anything from 5 to 80% prevalence of AKI in these patients, but they tend to either be specific groups like critical care patients or in all comers to a hospital. So what I've tried to do here is show you how common AKI is in patients seen by acute medics. So this is local data from Salford. We took all patients seen by acute medicine through March and April of this year. And these are people who were admitted onto our AMU, onto our high care unit, onto a cohort ward. So this wasn't people taken directly to critical care or other specialties. So on this slide, the red line represents the proportion of patients with COVID admitted each week from the start of March who had an AKI. So you can see around 3 weeks in, it peaked at nearly 40% and then gradually began to drop. The blue line is the proportion of non-COVID patients who had an AKI. And again, that peaks at week 3 and follows the same pattern of dropping afterwards, to the point where towards the end of April, we actually had very few AKIs. I do think that the peak in the non-COVID AKI probably does represent to some extent undiagnosed COVID patients. So this was 2,100 patients, 277 AKI confirmed on PCR there, and that was actually just under half of the total positive COVID patients we had during that period admitted under acute medicine, which I must admit was fewer than I had thought we'd have. I thought we'd have the bulk of the COVID patients coming through, but in fact we didn't. So moving on, and this is probably the slide that people really want to know. This is what's the impact of AKI in terms of survival. So if you look at the blue bars, that's the mortality in non-COVID patients. So non-COVID patients without an AKI have about an 8% mortality, working up to 34% mortality in people with an AKI3. For COVID patients, it's obviously a lot worse, to the point where COVID patients with an AKI2 or 3 both have a mortality of just over 80%. So we obviously usually think of AKI3s as the severe AKIs, but in the context of COVID, the AKI2 patients seem to do just as badly. These are AKIs onset anywhere. So these graphs show the location of the onset of the AKI. So for the first of these on the left, it shows that in non-COVID patients, around 65% of AKIs are present at the point of entry to the hospital. For COVID, it's just less than that. If you look at the graph on the right as you're looking at it, it shows the percentage mortality by location of onset of AKI. So we'll obviously see people whose, if they've already got an AKI when they arrive, they'll have an ED-based AKI, they'll have a community AKI, and in that setting, just over 60% will die while they're an inpatient. If you break that down into AKI stage, for AKI1, it's about 55%, AKI2, 75%. If you see an AKI3 in A&E or on AMU in a COVID patient, 88% of those in our hospital died. So it's a barometer of poor outcome. This looks at prescribed medication in the community and how that bears on outcome in AKI for non-COVID and COVID patients. So firstly, I've circled the non-COVID patients. So the blue ones are people who aren't on these drugs, and the red lines are people who are on these drugs. So in the general population, non-COVID admissions, if you're on a RAS blockade, MRA or a loop, then your likelihood of getting an AKI is higher than if you're not on those drugs, which I think is what we expect. If you come with COVID, then there isn't any difference between the AKI rate between those who are on and not on those drug groups. So we can postulate that this might be because the mechanism of AKI is different. Perhaps in the COVID patients, we're seeing fewer hypovolemic patients. Maybe there's more hypoxia, thrombosis, viral disease causing AKI directly. And of course, these drugs won't necessarily affect those in the same way they would the other AKI, the dehydration. So that brings us on to a little discussion about the pathophysiology of AKI. So, I mean, I wrote this list before I did the number crunching for those graphs that I showed you, and I just intuitively put all the iatrogenic factors at the start because I just presumed a lot of the AKIs would be hospital onset, to do with the drugs, running them dry and things like that. But I mean, we've just seen that those drugs don't seem to impact on it at the front door. Most AKIs occur at the front door. So, to what extent are these other factors involved? I mean, I say that dehydration doesn't seem to be a predominant factor, but then speaking to colleagues, I think we're all quite convinced that these patients, the COVID patients, almost by default dehydrated when they arrive. But looking through some of these other factors, in the severe respiratory disease, hypoxia may be contributory. The kidneys are very sensitive organs. Does that mean we need to aim for the top end of the target SATs range for these patients? Are AKIs driven to some extent by secondary complications from underlying conditions? Is it concurrent sepsis? Is it a DKA? We do know that comorbid factors are very important in predicting the onset of an AKI, and obviously they're not things we're necessarily going to be able to immediately modify for, but it is very important that we are sort of acutely aware of these things. The ones at the bottom are the sort of direct viral injury pathophysiologies, and I mean there have been some small series looking at the post-mortem findings in renal tissue. There was one study, I think it was from Wuhan, 9 of 28 patients had renal injury, and in those post-mortem renal biopsies there was some rhabdo, there were some interstitial findings, there was viral load in the tubular epithelium. So there was none of the, there's no microthrombosis, which we talk about as being a contributory factor. So I think what we need to concentrate on, I suppose, are the things that we know that we can modify. So I'll just move on to that. So I'll just talk about the assessment of the patients, and I suppose to start, it's mostly about some of the basic principles. And really, the first thing is about context. When we're seeing a patient in the height of a wave of COVID, before we know the swab result, because of course we're seeing suspected rather than confirmed COVID, in the middle of March, the pre-test probability of a patient with a temperature having COVID was very high, and it likely being bacterial sepsis was relatively low. Whereas if I see someone now with a similar symptom burden, it's going to be different. So judging whether or not it would be appropriate to give something like a potentially nephrotoxic antibiotic, it does need to be taken in the context of where we are in terms of the outbreak. Another factor is that because we know that AKI are associated with poor outcomes, that doesn't mean that the AKI is the cause of the bad outcome. And this is one of the challenges we're seeing with the concept of running them dry to prevent ARDS, and did we go too far with trying to protect the lungs and causing kidney injury? But equally, if we then focus purely on preventing AKI because it's a marker of bad outcome, are we going to cause more lung injury? I mean, this is similar to the situation we've had recently with heart failure patient care, where we know that there's always been a drive to try and reduce acute kidney injury, but heart failure patients do seem to be a very vulnerable patient group, where in actual fact preemptive cessation of things like ACE inhibitors and ARBs may actually lead to worse outcomes because of harm caused by sort of worse heart failure prognosis from stopping the drugs. So we need to think about that. The last three there are really things to be taken in context, in that when we are trying to make decisions, what we're doing is we're trying to do the best we can in the setting we find ourselves in. The goalposts are constantly moving. When people do retrospective reviews of how we treat these patients, a retrospectoscope is a powerful tool that we don't have. I think as long as we're satisfied that we're doing the very best we can, we've got a clear rationale for what we're doing, perhaps we seek second opinions, as long as the documentation is clear, and the right conversations to have with patients, I think that's all we can do. And these are also about shared learning. There's plenty for us to do in terms of sharing our experiences. There's data collection to be done, contributions to trials. So I'll move on to the assessment of the patient. I frame this really in terms of, are they going to need fluid? So that, I suppose that's the question we're always asking. So I've done this in the order: have they already got an AKI present? If not, is there clinical evidence of dehydration? If not, is there are there acute factors that pose a risk for dehydration or AKI? And then finally, beyond that, are there comorbid factors that may also contribute to the risk of onset of an AKI? So if someone already has an AKI, and you probably see I've got a slight obsession with heart failure, I do always try and consciously ask myself whether or not I think heart failure is a differential diagnosis, partly because some of the symptoms are similar, and also because if you think heart failure is a likely diagnosis as a differential, then that changes the course of management quite profoundly, but most other things won't. So once I think you're satisfied that heart failure isn't present, and then you can look to provide IV fluid in most cases, I think is our anecdotal experience. Factors that indicate clinical dehydration, I think we're all aware of these, and they sit alongside some of the acute risk for things that can lead to dehydration. So persistent fever, people are going to have a reduced oral intake overnight. People may be oliguric, and we need to remember that an AKI can be defined by reduced urine output as well as the creatinine value. So we need to very closely monitor urine output. If there's a 40% chance that these people are going to get an AKI, the urinary sediment. If everyone's going to get a dip probably. If there's proteinuria, hematuria, does that indicate worsening or potential for worsening kidney injury? Rhabdo is probably underdiagnosed in these. I mean, we are doing more and more CKs, but not universally. As I said, that rhabdo seems to be present on some of the renal biopsies at post-mortem. I mean, thrombosis, I think we're aware that microthrombosis and PE are present in a lot of lungs in COVID patients, particularly in critical care. There's a theory that does occur in renal tissue as well, and that I think that will probably have some evidence base behind it soon, but it's not practical or possible to make a clinical diagnosis of that, and we're certainly not going to change a thromboprophylaxis approach on the back of an AKI. It's just not practical, and we have to think about the fact that we would need to change the dosing anyway if someone's got reduced renal function. I've mentioned hypoxia before. NIV can contribute. So I think the main thing here is that all of these things individually can contribute to risk for an AKI, but most of these patients are very complex. So we need to look at the additive effect. How many of these things are present? And then finally, there's the comorbid risk. Again, if you've got CKD, hypertension, coronary artery disease, age, these are going to be things that will increase your risk of an AKI. So next, investigation. So again, I've talked about a lot of the investigations you would want to do in terms of how they link up with your assessment. These are some of the specific things that are either advised or that we tend to do. I'll just pick up on cystatin C there. I've put that in because I think that with COVID, we're seeing phenotypes of patient coming through the front door that we don't necessarily usually see. So we're seeing people with low body mass that don't usually come in, inflammatory bowel disease, some of the COPD patients, some of our parenteral nutrition patients. And we're finding that if someone's got, say, a marginal elevation in creatinine, but they've got profound acidosis or hyperkalemia, if you measure renal function with cystatin C and creatinine together, you'll get a more accurate measure of the renal function, and you'll generally find that it's lower than if you just use creatinine alone. Urea creatinine ratio seems to have a little bit of traction. I mean, I think we know that it can represent dehydration. I tend not to use it as a standalone test. Again, moving on. So I think historically, if we think someone might need IV fluid, we'll probably give it to them anyway. If someone does need IV fluid, we tend to just give 24 hours worth and just squeeze in a few bags. I wonder whether the days of doing that are over, and whether we're going to be moving to a model where we tend to do it one bag at a time, or we do more frequent clinical reviews of these patients because we're concerned that we might be overdoing the fluid. I think catheters are probably not quite as necessary as we think. I've put in there just a comparison of the electrolyte concentrations of plasma and sort of the more common fluids we give, just to remind people to prescribe it based on physiology as much as you can, rather than just quantity of fluid needed. I'll just quickly talk about medications. I'll go through these specifically. Antibiotic dosing, I think normal rules apply broadly for things that would need reduced dosing. Gentamicin might be the exception, where personally I try and seek alternatives to gentamicin given the complexity and the high risk from AKI. Trying to reduce other factors is probably important. I mean, opiates, I tend to reduce dose of opiates if people have got an emerging AKI, particularly given the severity of lung disease we're seeing. RAS blockade, I mean, the background, in the background, we should continue them. There is some guidance from NHS England that if you think someone's at very high risk of an AKI, then if the drugs aren't essential, then you can suspend them. Again, my obsession with heart failure comes out here. I think normal rules apply where really with heart failure, unless there's a definitive AKI, hyperkalemia or hypotension present, try and carry them on. Non-steroidals, I mean, if someone's at risk of an AKI, do we stop them? Do we carry them on? I think with any analgesia, I think the main thing is not to stop an analgesic in a patient without discussing it with them, because taking away someone's analgesia can cause a lot of distress. So a discussion is important there. Diuretics, again, I mean, there's no point giving IV fluid and diuretics at the same time generally. Metformin, I think metformin is probably safer than we think. It doesn't carry the risk of hypos in AKI and CKD that we see with insulin and sulfonylureas. I think the risk of lactic acidosis is overstated. SGLT2 inhibitors should be stopped because of the increased risk of DKA and severe illness. Digoxin, I would usually say that the maintenance dose probably needs to be lower in reduced kidney function, but they can be loaded in the same dosing as normal. IV contrast for CT, that's primarily risk versus benefit, isn't it? The main thing I think with these patients is really to try and avoid, or we get lots of requests to say, if you're going to have a CT with contrast, you need to dialyse them afterwards, and there isn't really much to support that. There might be the odd case, but by and large, a wait and see approach to dialysis is by far the best approach. And finally, low molecular weight heparins. I mean, there's lots of different policies around with COVID at the moment, but generally I think it's local policy. So I think the key messages from this overall, from this little discussion are: one, AKI is very common. It's a very strong biomarker of risk in COVID patients. And secondly, and it's multifactorial in terms of the AKI origin, and good supportive care, good monitoring, good basic measures, I think, are the most important thing. And then again, I don't know if we're sharing the slides, but if we are, this final page contains, each of these has got a hyperlink to the relevant documents, and most of the things we've discussed. And there's a few things we've not discussed, things like renal replacement therapy options on ICU, which is not necessarily relevant to us, but might be of interest. So that's some documents for people there.
Lovely, Darren. Thank you very much for that and for being the first speaker. We've had quite a few questions, but first, could we go to a question that came in via email? You've covered it a little bit, but sort of the rationale between ARBs and ACE inhibitors and their use, because there was lots of stuff coming out very early about how they were going to be protective. We've touched a little bit on heart failure about where they're important, but can you just clarify a little bit more around the use of ARBs and ACE inhibitors for us? And then I've got a few more questions for you.
Yeah, so I think, I mean, the conversation has arisen really because of the apparent, there's lots of theories about how ACEs and ARBs interact with ACE2. So some animal models have shown that ACE inhibitors and ARBs increase production of A2. And then A2 is obviously the means by which the coronavirus gets into the cells. I think clinically there's no good studies that show that there is a defined better or worse outcome clinically because of this relationship. There's postulation that ARBs are more beneficial because they block the route more downstream, so they may prevent some of the cellular entry. I think it's mostly postulation. I've not seen anything convincing either way. Certainly in the background, pretty much every societal guideline says carry on as normal. In terms of the AKI risk, the NHS England's statement, which is here, just says, if you really think AKI is very likely high risk and the drug is non-essential. So, for example, if they're on it for hypertension, but then their blood pressure is a bit low, you could probably suspend it if you're that worried, or you could seek an alternative. RARB is more favourable. I mean, I don't see a reason to switch from one to the other. I don't see a reason to start one of these drugs preemptively if they don't need it. I would just carry on as normal. So with the heart failure ones, we probably need a slightly higher threshold for suspending them, given that, or systolic heart failure, given that there is a potential for worse heart failure outcomes.
And sort of following on from that, we've had a question or a comment around, are we seeing more AKI and COVID patients on ICU who are ventilated rather than AKI in the normal non-COVID population? And following on from what you've just been saying, someone has commented on that question about whether it's microthrombi that is the driving force for AKI. So maybe you could do both those together.
Yeah, so the ICNOC, in April, ICNOC published a paper showing, I think it was about just over 2,000 COVID critical care patients, and they compared it against just over 5,000 pre-COVID viral pneumonitis patients on critical care. In those arms, the COVID population in that study, 19% of them needed renal replacement therapy, and in the pre-COVID viral pneumonitis, it was 17%. I mean, there are phenotype differences, there are characteristic differences and outcome differences between those two, but it doesn't seem that the AKI event rate in that setting is any different in COVID compared to other viruses. And I think as well, if we look at it from a fairly basic point of view, we've all seen viral pneumonitis. We've probably all seen people as sick as the COVID patients we've seen, but we just haven't seen so many just suddenly appear in front of us, with other, things going on as well that we just aren't really comfortable with. And we don't, I mean, I can remember so many of the COVID patients I've seen individually, but I can't remember any of the sick viral pneumonitis patients I've seen in the past. And I wouldn't have a clue how many of them had an AKI, because if people come in the front door with an AKI for most other things, it's sort of par for the course. So I wonder whether we're looking too much towards what's the COVID specific stuff, and there's this academic rush to, we want to be the first to describe X, Y, or Z, and maybe we need to take a step back and say lots of the basic things that are common elsewhere are probably common here. And the microangiopathic question, I've no idea. I mean, the post-mortem data that's been released doesn't seem to show that as a common finding. It's not like we're doing lots of post-mortems in these people though here, so that doesn't mean it's not heavily present. As I say, the one from China, there was a bit of rhabdo, there was some tubular injury, there was some undiagnosed diabetic nephropathy, there was some vascular changes from hypertension. So I'm just going to say I don't know, if that's all right, to the microangiopathic question.
I think that's fair enough. We've had another question come in from Mohammed, who says, what are the thoughts of the panel on IV fluids with those presenting with respiratory and GI symptoms? Are we contributing to their admission to ICU with excess fluid? And I think this goes back to the keep them dry, run them wet dilemma, doesn't it? Have you got a comment on that?
So well, we had an MDT with our critical care team. I think there's one or two of our critical care team here. I think when these people get up to critical care, even when when they need ventilating, the feeling up there, I think, is that most of them are dry. So I don't know if anyone wants.
That's always what anaesthetists say.
Say that again.
That's always what anaesthetists say.
So I doubt we're causing that much ARDS, and I think if again the intensivists, and there's plenty of them here, I'm sure, will know more than me, but I gather that the evidence for diuresis and running people dry with ARDS is that if you look at the meta-analyses, it's when people are in that critical care setting with severe ARDS, then dehydrating them can lead to a better outcome. Whereas if someone is already dehydrated before they get to critical care and they're tachypneic, tachycardic, hypotensive, they've got an AKI, they've got GI symptoms, and they look dry, then where's your risk? I would say it's everything else at that stage. So I I don't again, I don't know, but my gut feeling is that we probably do need to give more people fluid. And one of the things we want to do a deep dive on that first graph I showed you was, that peak in AKI, and it started to tail down. I don't know whether that can coincide with when we started to be a bit braver and give more people fluid. Okay, I think that's one of the things, as acute physicians, we're in a privileged position to be able to collectively gather huge amounts of data on thousands of patients. I think we should be one of the key people in trying to collectively work together to look at what can we do at the front door. And that's, if we know when we change practice away from running them dry, we can perhaps see whether or not that was the time when AKI is reduced. But then the big question, as you asked there, is did we get an increase in the number of people being vented? That's probably something we can, as a society, we can look to do.
Perfect. So there are a few more questions, Darren, if you don't mind looking online and on the Q&A and see if you can do some live answers, because you've generated quite a few questions that people want some answers to. So that's brilliant. Thank you very much for that. We're going to move on now to our next speaker, who's one of our oral presentations from our posters that would have been. So it's a delight to welcome Owen. And he's going to talk to us about workforce wellbeing, which is something that's going to be close to all our hearts. So welcome, Owen, and thanks.
Well, thank you for giving me the time to speak today. My name's Owen Dorr. I am an ACCS trainee in Birmingham. My Twitter is labelled there. I've just started it up to try and get the message of this stuff out. And I think COVID is a bit like a Pandora's box. I think one of the things that we left is that as doctors, we're human, and optimizing ourselves and looking after ourselves does and will result in better outcomes for patients. I have to acknowledge the other people who have really worked hard on this project: Marine Anwar, Andrew Holden, and the consultant leads, Saab Claire, who's really got behind us. So I think, as with any presentation, tell them what you're going to tell them, and then tell them again at the end. Just go through the introduction, how we came about this project, why we did it, how we kind of specifically went into well-being, and what the results are, and hopefully it will spark either a conversation at your unit as to how you would like to take it on. I think the first thing I'd like to get onto is, why is it important? So firstly, I think well-being suffers from being far too vague. It can range from crystals to giving out free soup. And I quite like to identify it as looking after your energy, your performance, and your mental optimization. And in some ways, try and think of yourself as an athlete. You wouldn't ask Andy Murray to play on centre court at 4 a.m. So why are we asked to go to resus and make very tough decisions, do high complex tasks, and not expect that we would be affected by that, and also think about how to optimize ourselves? The other reason it's quite important is that actually, if you look at our life expectancies, they're actually reduced in comparisons to general population. One paper that makes for tough reading suggests our median ages of passing away will be 72 to 76 in comparison to the UK population of 82. So kind of looking into ways that our job affects us and how we can modify that is quite important. And one of the areas to focus on is night shift. Night shift workers have a 40% increase up to risk of stroke, diabetes. You double your risk of road traffic accidents post night shift, and you also double your risk of mental health illness. And given some quite high profile junior doctor suicides, I think this is why it's very important to focus on this. So how does this reflect to us at SAMinar West Birmingham? Well, actually our acute medical trainees, core medical trainees, had a 60% burnout rate of moderate to severe symptoms. One of the main causes of this was post-night fatigue. And we also received the maximum amount of MERT funding for burnout in our trust as recognised by the BMA. And that's specifically for wellbeing funds. So what do we do? Well, actually wellbeing is a very big puzzle to fix. How do you fix people's happiness? And I think one of the most important things is to take little chunks and improve your modifiables. So one of the little chunks is how we rest overnight. There's been really good research by the Royal College and by Michael Farquhar that shows that power rest for 20 minutes improves your alertness and your effectiveness. So that's kind of where we aimed it. And it was aimed as part of a bigger cultural change, along with other things, to try and spearhead a project on well-being. So this is what we went into. I don't think there's any point getting the world's best sleep facility, getting a lovely room, if people can't use it. And obviously, as acute medics, it's one of the toughest jobs in terms of workload. There's never going to be a time to take a 2-hour break, but there is time to have a look and see where you could maybe take 10, 20 minutes and how you use that. IMU was no different. Out of 60 people, I think it was about 55 took less than 30-minute breaks, and there was out of only one person had a suitable area to rest. So that's what tried to drive our culture change. And Saab Player was one of the main consultants asking people at handover at 8 a.m, okay, did you rest overnight? Did you use the facility? And that kind of approval by the bosses allows the juniors to feel that they could use it. We then looked into the facility change and got some sleep pods, which I'll get onto later. And we looked at an education arm for the benefits of this and how you can improve your overall well-being. And we also took an MDT approach to try and include our nursing staff in this as well, and have them access at selected times to allow junior doctors to use it when they were peak times for rest between midnight and about 6 a.m. And we surveyed. So one was immediately post the pod, and the other was at the start and end of the project. So this is a sleep pod. I'm not a rep for sleep pods. I do think they are better than hospital recliners and beds. They do look a little bit funny. They were first used by Google, and the reason they use them is that you can quickly switch off. Instead of like a bed where you have got a noisy environment, especially on a busy AMU, you've got something as sensory deprivation. You can see that our model here has headphones on, the chair vibrates, and you can swing it round. And it's particularly been of use post-cardiac arrest for people who are very upset, who didn't want to have maybe a sleep or a snooze, but needed to switch off, needed to change gears. And just if you don't sleep in it, if you power rest in it, you can come back to work more effective. So did it work? Well, yeah, it did actually. Out of 30 people surveyed immediately after, 85% felt more energized, 83% more alert, 90% recommend to a colleague. So look, it doesn't work for everyone. Some people, a small section of people want to bed instead, but again, it doesn't allow for that quick turnover that you need. And also it doesn't allow for the quick changing of gears. And the feedback was qualitative, was really good. People felt calmer, whilst at the time of the pod they felt more relaxed, and people liked it. And the more important data was longer term. At 3 months, people were surveyed again. We decreased the burnout rate in the conjunction with another project which looked at debriefs from 60% to 20% from moderate to severe burnout rate. They also saw an increase in people taking breaks, increase in energy levels, and a decrease in post-night fatigue. And a knock-on effect was that people felt that night shifts had affected their physical health and personal relationships less as a result of measures that have been brought into AMU, which I think is increasingly important as we look at retention of trainees. So discussion, I really think that hopefully this could just promote a thought of what are the rest facilities you have? Are they accessible? Can your doctors use them? And if not, can you promote an environment of a 20-minute power break where someone can go and they can sleep if they want to for 20 minutes, or they can just completely switch off. And that is probably why sleep pods or something like them are a bit better just than a standard recliner or bed, because it allows for that and also allows quick turnover. The breaks have been vital for people. It helps facilitate kind of a spearhead campaign for people to take them. Otherwise, if we burn out, we're not doing our service to our patients. I mentioned about the sensory deprivation. I think the important thing to mention is, as I mentioned before, I'm the JDF chair and also the wellbeing chair for the trust. It's part of a larger puzzle. You need to have culture change. You need to have support from higher up. So we've had to go and speak to trust boards, and they've bought in, and we've rolled it out to the. We've rolled out quite a lot of measures such as debrief clubs. We've revamped all our rest facilities for doctors. We've got people access to counselling. We've got an engagement arm. We've made wellbeing videos. And some of our burnout data is less during the COVID, not when we're less busy, but actually during the COVID period than it was before. I think it shows that these little 5% changes can make a huge addition to the department and to how people perform at work.
That's brilliant, Owen.
Thank you.
Thank you so much for that. And it's really good that wellbeing has been included, isn't it? Because it's really important to all of us now. A couple of questions that I've got and a couple of questions that are coming online. The cost of the pods is massively prohibitive, isn't it? And it sounds like you've got a lot of money from the deanery grab out. How much do they cost and how many do you have?
So firstly, we got £60,000 from MERT funding, but actually the trust are the ones who bought them because we use it as part of an MDT project. They're £10,000 each. However, I would argue that if you're able to reduce your post-night fatigue and you're able to get more staff on floor and have less of a sickness rate, actually they are worth the money of investment or something similar. So I don't think that it would be unreasonable for other people to be able to get them. We managed to get off the company we've got 2, so 1 for each AMU because there's 2 hospitals in our trust. And just another 1 for maternity. Sorry.
Just before we finish, there's a comment about whether pods available in the day, but I think you answered that because it's like a really excellent resource sort of from a post-arrest or difficult thing, you know, difficult decision, difficult outcomes, whatever, that you can use them. So thank you very much for that. I think we will now move on to Mohsin if he's ready. And Mohsin works at Northampton and he's going to talk to us about diagnostic reasoning. Over to you, Mohsin.
Thank you. Thank you for the opportunity. I'm going to start this talk by giving some context to how this all came about. So I had a horrible week where people were making decisions which made no sense to me at all. And given that, thought there might be an idea to actually structure some kind of training around it. And since we were doing that, we thought might as well get an idea of what people actually think how decisions ought to be made. So before I go any further, let me go through this slide. Basically, we know for a fact that 10 to 15% of the time, the medical diagnosis is not right, and that irrespective of where you are, anywhere in the world, this could be true. A lot of the doctors worry about making the wrong diagnosis, and that again is represented throughout all grades of training. We also know that the wrong diagnosis is the most common cause of medical errors. So what we did was that we designed a whole training module in the 20 common presentations. And then we went through them one by one, but for each differential diagnosis, we gave them a clinical case to begin with. And what I'm going to discuss today is that clinical case for the patient who presented with chest pain in theory. So, for some reason, I can make it go. So this is the case we actually gave them before we actually taught them how to approach chest pain. And what you could see is we have given them the scenario of a 55-year-old male who's got a background of smoking, diabetes, hypertension. But what we asked people to do was that as each and every one of these factors became apparent, they had to give a percentage probability of the patient having acute coronary syndrome. So they only first of all knew that it's a 55-year-old who's presented to ED and they have to go and look at a chest pain. And then we told them he's actually a smoker, he's a diabetic, he's hypertensive, and that the pain is radiating to the left arm. And then when they go take a history, it turns out pain radiates to both arms. So basically giving them different factors and see how they put different weightage on those factors. And just to be clear, because every time we said troponin positive, we anticipated everybody would think this is the diagnosis made. So we actually asked them to see, like, once they have been told trop is positive and they've given a probability, we said the labs called back saying trop, it was a wrong, faulty result, trop is negative, so that they can then give a post-test probability of what they thought this was. And this is basically a breakdown of what we thought the probability was, or what is the known probability based on the likelihood ratios and what people thought. So as you could see, the pretest probability was quite high given that patients presenting with ED have a quite high likelihood of this being ischemic. And after that, every typical thing that we give in history usually, or we teach people that they are male, they're hypertensive, they're diabetic. All those traditional factors you could see they were given higher weightage than you would otherwise anticipate. The thing where it all changes is radiation to the left arm. You would anticipate that people would think that's very specific, but radiation to both arms, which has a much higher likelihood ratio for being acute coronary syndrome, was actually reversed, where people gave it less weightage than what should be there. And similarly, troponins got a lot more weightage than they should be. And again, you see the ECG being normal has less weightage in ruling the diagnosis out, but people were more confident in ruling it out based on that. So that's what we typically saw. These are some of the slides from the teaching session. And as you could see, the way we divided the teaching was that the 4 top diagnoses might not be the most common, but you're most worried about. And then you keep going out to the very bottom, where we technically say that's what you anticipate the GPs to sort out and send them home. And then there was a teaching session looked at each and every one of those diagnoses. So we're just going to go to one of the slides of ACS, which is basically just looking at the risk factors. But we went through risk factors, history, examination, investigations, and scoring systems. And for each and every one of those, we used the likelihood ratio bar, where they could see how presence of any one of these can either make the probability of the diagnosis much higher, much lower, or doesn't really change it a lot. And in this particular case, you could see smoking or being a male don't really change the diagnosis as much as you would think. On the other hand, having peripheral vascular disease really does change the diagnosis or probability of the diagnosis at least quite significantly. And none of the trainees we were talking to actually considered that as something they would even ask in their history specifically. So we took feedback after each session, and the feedback for this particular session was that people were overestimating the importance of traditional factors, as you've seen in the graph. They were focused on looking for patterns. So just pain didn't matter. They were looking for, they were sweaty, clammy. They assumed that investigations were a lot more accurate, and that's true both for ECG and for troponins. And they really they did not approach things as how does the weightage change as different factors come into play. It's very much looking the pattern of you're a male, you're a smoker, you're hypertensive. And if things didn't fit that pattern, they were really struggling to come up with a probability unless investigations were there to support it. And from all of this, what I concluded, or at least we concluded, was that the current methods of training focus very much on diagnostic error. We are very much train people to think, what if you miss a diagnosis, rather than how do you make a diagnosis? And so we don't really consider diagnostic error in the right context. We do not focus on evidence base. A lot of this is traditional training points that we continue with. And the teaching programs frequently focus a lot more on presenting complaints rather than how the approach need to be made in a particular context. And I think I've gone through this much more quickly than I anticipated.
That's it. Well, thank you very much, Mason. That's good, because we'll have time for some questions. So I agree with you. I think pattern recognition is massively important to doctors, and I think it becomes more important the more experienced you become, because your pattern recognition has become so honed. So rather than just clinical reasoning, what do you think about, you sort of mentioned pattern recognition and we're not keen on it. I think actually the more experience you get, the more you use pattern recognition.
Well, that was the thing. Since we were looking at different ways of teaching people, we realized that the older the people were in our training audience, the more difficult they found the whole training session. And that's true from all the international data we have on teaching, that the more experienced you are, you have already developed your approach to a diagnosis. And whenever we try to change that or try to make you move away from that, we find that the risk of error actually goes up. And so those who have trained, there's no point in trying to teach them this now. Time is gone.
And have you done any data to see whether their diagnostic skills have improved? So is there a difference between their before, when everybody came in, I'm assuming chest pain query ACS, Have you done any data to look at what happened to those people who've been taught and whether their behaviours have changed?
So behaviors have changed a limited number of people. My problem is, given acute medicine, people keep on moving along quite a lot. I was only left with 4 people in the group once this particular session was given. We did realize that out of those 4, 1 after 3 months when we reevaluated their practice had not changed. The other 3 did continue to do what we had suggested they do. But there was one person who was like, no, I tried to do this. I got told off that this is how to approach the problem, and I've stopped.
That's brilliant. I can't see any other questions that we haven't gone through. So I think, shall we take a break now? So we're now very pleased to welcome an old friend of mine, Ben. We worked together many, many years ago in Southampton, and he is very important in all things to do with the curriculum. And he is going to give us an update on how the new curriculum's changed, which should be really helpful for all of us. Off you go, Ben.
Okay, thanks very much for that, Sue. My name's Ben Chadwick. I'm an acute medicine consultant from Southampton, and for about the last 3 years, I've also been the chair of the Specialist Advisory Committee at the JRC-PTB. So overall, we have responsibility for training across the 4 nations in acute medicine. So any of you trainees, I am ultimately responsible for your training, which may or may not fill you with dread. What I'm going to talk to you about today is just what's happening around developing a new curriculum. And you might ask yourselves, well, why do we need a new curriculum? The old curriculum's been around for a while now. It was originally set up in 2009 and modified in 2012, and really hasn't seen a lot of change since then. And during that time, ideas around medical education have changed, and so there is a need to look at things. Part of this is driven by the GMC, who are the regulatory body who oversee our curriculums, and they have revised their guidance around what they consider good practice to be in curriculum development. Also, within the JRC-PTB as well, there's an understanding that we need to review the curricula as well, and certainly from the point of view of the Society of Acute Medicine, they've been quite active in driving change in medical education. And I think, you know, one of the very valid criticisms of the curriculum that we're running with at the moment is that it has become quite tick boxy. So there's a lot of competencies to sign off. You have to get a lot of evidence against those things, and it's become quite cumbersome. So we started work on developing a new curriculum. And part of that process really was thinking about, well, what do we think works well at the moment? And, you know, amongst the representatives on the Specialist Advisory Committee, which include TPDs from across the 4 nations, trainee reps and lay representatives, these are some of the things that we liked. So we liked the fact that there's a fairly broad base to our training, and we liked the idea that people did periods of time in important specialities such as respiratory, geriatric medicine, and cardiology, and also the intensive care bit was felt to be really good. We also liked the idea around the specialist skill, which has been really a helpful thing in driving change through the curriculum and also engagement with the curriculum, and that's been a real success, so we wanted to keep those. What do we want to improve? Well, one of the main drivers to change this was to try and establish acute medicine a bit more as a speciality in its own right. So, as those of you who are training in our AIM and GIM know, the AIM and GIM curricula in terms of the competencies are very similar. And what we wanted to be able to do was to make a more clear distinction between what we felt is GIM training and what is acute internal medicine training. And part of that was making a real emphasis on the areas where we feel we do have specialist skills and knowledge. It was also a chance to think about how things were changing in terms of point of care ultrasound. It's becoming an increasingly popular specialist skill on one hand, and on the other hand, there are elements of it that everybody needs to be able to do in terms of chest ultrasound and things like that. So there was a driver to think about, could we integrate that into the core curriculum? So rather than being a specialist skill, it became something that all acute medicine trainees would train in. And another big thing that we're trying to achieve, and we don't know yet whether we will achieve it, is trying to embed some more protected time for training within the curriculum and make it much more explicit. So as things stand at the moment, we suggest that in order to train for your specialist skill, you would need about a half day a week, for instance, on average across your training program in order to achieve that. But we know from trainee surveys and various other things that that isn't by any means universal, and some trainees struggle to get it. So what we wanted to do with the new curriculum was really make a much more explicit statement about moving towards a model of training that protects time for things like the specialist skill, point of care ultrasound training, and other things as well. So those were the things that we wanted to work on, really. The biggest change in terms of the curricula is a move away from individual competencies in people presenting with abdominal pain, for instance, to much more generic ideas of these competencies in practice. So those of you who are doing IM training at the moment will be familiar with these. Those of you who are educational supervisors to people in IM training will be familiar with these. But the idea about these things is that there are much fewer of these competencies in practice, and they're a much more holistic assessment of how somebody performs within a workplace. So it's a move away from the kind of tick boxes that we've had before to a much more holistic, more nuanced maybe judgment of how somebody's progressing as a trainee. There are challenges to that in that it does put quite a lot more emphasis on the opinion of an educational supervisor. But I think that's what we would expect of our educational supervisors. They are able to give an opinion on how somebody is training and how somebody is progressing. And so the first stage of doing this was really to start to develop what should our competencies in practice be. So the model for all of the Group 1 medical specialities is that there are the core generic SIPs, which are embedded in IM training at the moment, and also there are internal medicine speciality SIPs, and there are, I'm going to say 8 of those. And then in addition to that, the acute medicine SIPs bolt onto the bottom of that. And so what we wanted to try and develop within the SAC was some acute medicine SIPs that focused on areas where we felt that this was, these were really important areas where acute medicine offered a real specialist option, if you like. And so this is what we came up with. So a lot of what we do as acute medicine consultants is to do with managing the patients on the acute tech, but it's also to do with managing the acute medicine service. So we wanted to get something in that reflected that. We wanted to make sure that we had something in there about ambulatory care as it was, same-day emergency care as it now is. Who knows what it'll be in a couple of weeks, but that's what it is at the moment. So we feel as a speciality that we have a real interest and a real skill in dealing with ambulatory patients, risk assessing people for that. We also wanted to build stuff into the SIPs that made it clear that we wanted to continue to have a broad base of our training and still do cardiology, respiratory and geriatric medicine. And one of the big drivers behind all this change was a report of the Shape of Training report, and that emphasised the importance of links with the community. So we wanted something in there because a big part of acute medicine is linking with the community, working with community partners, both on patients coming in and going out. And we also wanted to keep the speciality skill. And there's been a huge amount of debate about what caused that, which I'll go into if we have time. So how did we do it? Well, a lot of the discussion has happened at the Specialist Advisory Committee. As I mentioned, they have representation from all the TPDs across the 4 nations are part of that committee. We have trainee representation and lay people there as well. We developed a kind of small working group who initially worked on the SIPs, which went out to consultation and were agreed. And then we've set up a small working group to write the document, which has been fun. As members of the Society of Acute Medicine, if you guys are, and if you're not, you should join. You've seen an earlier draft of the curriculum document, but that's currently working through version 5 and will be coming back out soon. In terms of the stages of getting it through past the GMC approval, we're still at a relatively early stage of that. So the first stage of that is what's called the COG, or the Curriculum Oversight Group. So they've seen a proposal for acute medicine training and our SIPs, and they've agreed that they think that fits with shape of training and the concept of general professional capabilities. But there is a further submission of the main curriculum document, which is coming up in October of this year. I think it's worth mentioning now about point of care ultrasound training. So there was a lot of debate about whether we could include this within the curriculum. There was an overwhelming feeling amongst the SAC that it would be a brilliant thing to have in the curriculum. And then it became about, well, are we going to be able to deliver it? Because obviously what we need to do is, if we are going to put this in the curriculum, we need to make sure that everybody can train in it and everybody has access to it. So part of that process has been setting up a working group which has looked into the feasibility of this. And what the feeling of that is across the 4 nations, that it should be deliverable. It's not necessarily going to be very easy or straightforward, but we think we're at the stage where if we give it a big enough push by putting it into the curriculum, then it is doable and deliverable across all 4 nations. And one of the TPDs on the group has also been heavily involved with the famous curriculum, which is the Focus Acute Medicine Ultrasound curriculum, and that's going to be the template for point of care ultrasound training within our curriculum. The specialist skill has been an interesting thing to go through and think about and try and get past the GMC. So it has to meet requirements for the GMC, from the GMC and Health Education England and across the other 4 nations as well. And initially it was pretty simple and straightforward in that we took a view that most things that were applicable to acute medicine and had a reasonable course to it, we would approve at the SAC. That became much more complicated with the change to study budgets, where effectively the cap was lifted, and if you were able to effectively claim for anything that was within your curriculum. So now what the health education authorities want and the GMC want is to make sure that this is value for money, if you see what I mean. And so a key part of that is not just being able to specify specific courses that cost a lot of money in order to develop competencies that could be made in other ways. So you may have seen that we've recently redone the specialist skill document in an effort to standardise it, and that was the first part of the process in getting a new curriculum draft. The other thing which has been a real hot topic is what do we call it? So originally this was set up when acute medicine was born. The specialist skill was kind of in there because it was felt that somebody doing acute medicine all the time, it would be too intense, there would be worries about burnout, and therefore people should have something else. I got through one of the very early versions of the acute medicine curriculum, and if you want to know what my specialist skill is, apparently I can put in temporary wires. That was my specialist skill, which I would never even attempt to do now. You guys now are using these skills much more sensibly, in that you're developing things that you can then use in your later career, and that's the idea. There was some thought that calling them a specialist skill in some way devalues acute medicine as a speciality. So you're acute medicine and you've got to develop a specialist skill. We thought about the use of subspeciality skill. That is a protected term by the GMC, and also there were some concerns amongst other people about it, again devaluing acute medicine. So we're not quite sure what we're going to call it, but we're keen on keeping it. So where do we go next? Final version is going to be shared really soon, and any feedback that we get on the curriculum is really helpful, really important, and it might be really minor stuff like spelling mistakes. It's quite a good idea to spot those, but equally, if there are areas of the curriculum where you feel either they aren't getting enough emphasis, or they've got too much emphasis, or there are things that are obviously missing, there is still time to tweak. If we get it through the CAG later on this year, then we start to think about implementation. So the idea behind this is that it will be implemented in 2022. And the big push is going to be around point of care ultrasound training, making sure we can deliver that. And also this all hinges on us being able to convince NHS employers, health education of the various bits of the countries about shifting to a model where effectively you have 4 days of clinical shop floor work per week, and then 1 day which is protected for training, and that 1 day would include point of care ultrasound early on in your training, specialist skill later on, and also things like audit and professional development. So that is me done about on 15 minutes.
Thank you, Ben. That was like time to absolute perfection. So as you might expect, there are quite a few questions for you to answer. But I'm going to start with one that was on the chat from James Bartlett, who said, is there a danger when you differentiate acute medicine further from GIM that you're further devaluing GIM, and it feeds the narrative that specialisation is good and generalism is bad? I'm sure you've got views on that. I certainly have. I'll let you go first.
So I think, in all honesty, there is room for both. So I see myself very much as a generalist, if you see what I mean. So I'm quite happy seeing a wide range of medical presentations, and actually that's what I like about my specialty, and that's what I like about my job. But equally, so I would reflect back to my time during training, where actually as an acute medicine registrar, I trained between 2004 and 2008. Nobody had a clue what an acute medicine registrar was. Nobody really understood what I was. And, when I was placed during my specialty placements with other specialty registrars, I got the usual thing of, I trained, and when I did sometimes a gastroenterology registrar, and I trained with somebody called Trevor Smith, who's now really important and really clever. And, I went to gastro clinic and he knew all this stuff, and I was like, oh my God, he's really clever. But then it was really noticeable when I did the acute take that I was much more comfortable than he was. And so, I think AIM and GIM, the two curricula, were too close as they were. And I think it's a really important step to start looking at us remaining generalists, but having our own little niche that we are demonstrably good at, and we are good at it.
Yeah, I don't think I have to add anything to that. I think that's the perfect answer. I think we are, with the geriatricians and the paediatricians, the last generalists, aren't we? But it doesn't mean that we don't have skills that other people don't have. So I think that's like exactly how I feel. So there are quite a few questions coming in, Ben. Someone's asked if enhanced care and SDEC are specific in the curriculum.
So,
go on.
Yeah, so SDEC is mentioned specifically. So it's one of the, I think it's the second SIC that we've got. So one of the things that we thought we obviously spend a lot of time doing is risk assessing and thinking, can this patient be managed in an ambulatory capacity? And it specifically mentions same-day emergency care because that's currently the name for it. I don't know what happens when they change it again, but So yes, it's in there.
There's a few on POCUS which we'll come to, and I'm
okay.
going to ask all the POCUS questions together, I think. But there's another good question from someone about CSER training and how CSER is becoming more common, and whether somebody's asking what's the chance of succeeding getting into AIM from CSER. I think it's brilliant, but have you got any more information? We've got at least 2 anyway, CSER people going through at the minute. What's your views on that?
So yeah, CSER training is a good option. I think there are a number of ways of approaching CSER training. You can either do it in a prospective manner, where you think, actually, this is the way I want to train. I want the flexibility of being able to work where I want and do what I want. I'm going to collect evidence against the current curriculum in the same way that I would do if I was training, and that's a much more straightforward way of going down the CSER route. Most people do it retrospectively. So they say, well, I've been working in this role for the last X number of years. I think I've gained enough experience, and then it's a matter of submitting against the curriculum. I think it's a valid and valuable way of training. I think most people who go on to get acute medicine jobs via a CSER route probably just get the CSER in GIM, would be my experience. We don't have a huge number of AIM CSER applications that we see through the SAC, but it's absolutely a valid way to train. In terms of how this will change, when this new curriculum does come in, then if you are looking to apply via a CSER route, then you will have to look against the new curriculum. But there will probably be a phasing in period where, even if we've, it will probably be from implementation rather than from when the curriculum is approved that you'll have to go on the new one.
So I can see Nick Smallwood's online and he's answering a couple of the questions by...
I'm sure he is.
Which is really good. And if he keeps doing that, if he's listening as well as typing, that would be fantastic. There is one question I can't find right at the minute about, here we go, from Rajit about what's the feeling re-existing consultants who will feel like dinosaurs when new colleagues can use POCUS? Is there anything thinking about bringing POCUS in for existing consultants? This is a question I ask myself every single day.
Yeah, so I think as time goes on, I feel more and more like a dinosaur, and I'm moderately comfortable with that. I think it's a really good time now to start thinking about how are we going to deliver this training from 2022. So one of the big focuses at the SAC over the last couple of meetings has been to get each TPD to think about how many people have you got who can act as supervisors for people who are going to train in ultrasound. And part of that has been, there is time now for, if within your area, within your unit, you don't have anybody who is trained in this, then actually there is the time now for somebody with an interest to say, actually, I've always really wanted to learn about this. Go off and do an approved course. Famous is one of these courses, and then you will probably be ready to be an accredited trainer by the time we're having to train people in 2022. So I think if people are interested in it, then now is a great time to get involved and to help train people as they come through. And
I'm sure Nick's answering some more of those online. So Nick, if you keep answering those, and Ben, you could come back to a few of them. There is just one more question there's loads of questions, Ben, so you can have a look at them at the end. But the one I want to ask is, someone has raised some anxiety about, I'm assuming it's about COVID and the lack of rotations and their ICU block. How that's good. It says, how will training be affected by M3? Will there be protected ICU block? And I'm assuming that's someone who is moving into acute medicine or their specialty and haven't got the necessary competences from IMT yet. Do you know what's going on with that, or do we need to do some digging with the JRCTPB?
So if the question is about, so there may be some people who are currently training in acute medicine who may have been stopped from rotating into a block of geriatrics, respiratory, cardiology, intensive care, or what have you. The basic principles around this whole pandemic thing is that, trainees shouldn't be disadvantaged by the fact that there's been a pandemic. So, what we would normally say is people do have to do a block of elderly care, cardiology, or what have you. But what we would say now, what we will say is that you know, if a trainee through no fault of their own has not been able to rotate to a respiratory block, for example, and they're really close to the end of their training, and it's going to be really difficult logistically for them to do a block in respiratory, then what we do is we look at an individual basis on some sessional exposure to respiratory. So, okay, you've got a little bit of training time left. There may not be enough for you to do a full block of respiratory, but actually during that time, you can do some respiratory clinics, and you can do some ward rounds on HDU or something like that, and that will make up your exposure. So I think, you know, it's important that we maintain some flexibility and we make sure that people aren't disadvantaged.
Perfect. So Ben, if you don't mind having a look, there's loads of questions as we predicted. Thanks to Nick S for having a look at some of the POCUS ones, and you can keep going, that would be brilliant. And thank you very much, Ben. We're going to move through now onto more of our oral presentations, and we are going to go to Michael, who works in Bristol, and he is going to tell us about how to structure teaching in only 3 hours a week. So over to you, Michael, and thank you.
Yes, thanks for having me. So my title is It's Only 3 Hours a Week, Providing Structure to Undergraduate Teaching on an Acute Medical Unit. And as that suggests, the original motivation for the project was to address concerns from educational lead and consultants working on an AMU, that the undergraduate students weren't making the most of their time, perhaps, when they were on the unit. That a lot of the teaching that was being done was ad hoc and unorganized, where they would approach some of the juniors and then do case presentations while they're on the ward, and a concern that was removing them from their clinical duties. So their original plan was to find out how to improve on that, and I hope we've come up with a way of educational leads can structure their teaching on AMU, and perhaps also give an opportunity for the junior doctors on the AMU for professional development, and also to give the undergraduates some satisfactory teaching. So as a background, when deciding where the teaching should come from, we're looking at the Royal College of Physicians Acute Care Toolkit, which is available from the Society of Acute Medicine also, that on an AMU recommends that work-based learning, i.e. learning on your feet, should be complemented by classroom sessions, but that's very much on your feet specialty, so the teaching should be done the majority of that way as well. I felt that the toolkit's focus is very much promoting postgraduate education, which is reasonable, and makes specific reference to consultant skills and consultant roles, and then in order to teach trainees. And I would suggest that that's less applicable in undergraduate medicine as it comes to a guide, because the students are on the placements for a far reduced time. They're in an unfamiliar environment. The learning opportunities are less accessible to them because of that. And also when they are being taught, as opposed to a trainee, they require a lot more closer supervision by their superiors who are imparting the education, again at the expense of the clinical duties of those doctors in the unit. So our aim was to see what could be done to improve on that and reduce that ad hoc teaching and that focus. So our method of collecting data was to survey the third-year students who were on their undergraduate placements. It was completed anonymously online for the most part, and had 15 questions. They were adapted from the Manchester Clinical Placement Index with some utility questions included, so we could find out how to direct the teaching. And in the stage of students who had not had any of before this intervention took place, the main concerns were that they felt that all of their teaching was self-directed in essence, and that there wasn't any organised teaching that let them address their needs and their questions about acute medicine. So the intervention that I thought would address this was 2 sessions over the course of these 5-day placements. They were 90 minutes long, and they were structured very much with an emphasis that the students needed to prepare in advance. They needed to find a patient, they needed to think of how they would essentially admit them themselves, and then compare with what had happened with the patients during their time on the AMU. We would meet up, discuss management as a group, usually a group of 2 to 3 students. That was the number of year 3 students on the unit. And then we would just explore one topic that was related to acute medicine. So in one session, they would find a patient whose presenting complaint was chest pain. We would talk through differentials, possible management of chest pain, and then risk stratification as the AMU related topic. And in the case of the headache session, it was risk, red flags. This continued over a 4-month period, and then after we performed the intervention, we re-surveyed the students who had taken part to see how they felt it had improved their experience during the 5 days. So results, and on the right are the results when the abstract was submitted. I unfortunately didn't update that, but on the left, I've got some of the kind of more pertinent, I feel, areas where things have improved. If you look on the right, essentially in every aspect that the survey asked, the students felt that the placement had become a better place for learning. And that, I can assure you, was repeated when we, that was repeated when we got more results. That didn't change. Everyone felt that they had benefited more. What I thought was most interesting was the areas where they had improved, and that these sessions had actually made students more capable of learning on the ward round. They were able to participate more and found it a better opportunity. As you might expect, their satisfaction with the amount of small group and bedside teaching increased to essentially 100%, which for a group of 29 medical students, I think is quite a good result. And when we asked them if they had a member of staff to approach, which is part of the Acute Care's toolkit advice that there should be an educational lead for a placement. Originally, only 1 in 4 felt that there was somebody they could approach if their leads weren't being met, and that increased to about 71%. As I say, improvement was clear over all of the questionnaires indicators. If looking back on the limitations, things that we can address going forward, the evaluation served as an index of satisfaction, and I think as a project, it did show that these 90-minute sessions twice a week were feasible and acceptable to the staff, but they didn't clarify that the teaching that they were receiving was effective. Now I feel it was. As one of the educators, I feel like we were able to impart a fair bit of knowledge on presentation, and the students would agree based on their free text answers on the survey. But that's something that we might want to address, maybe using assessment at the end of the placement. And also possible limitation, the extent to which the self-directed learning wasn't measured, and I think I would, in future, include student ratings on where their education came from. And in the free text, the students were citing that after we had performed the sessions, that's where their teaching had come from. But in the off chance that there was ad hoc bedside teaching to a greater extent later in the year, I think that would be a useful way of making sure there weren't any alternative influences that could have made the results less significant. So if I could conclude that I do think that on-ward teaching should continue to be the foundation of AMU education. That would be postgraduate and undergraduate. I feel that these structured sessions did have an immediate demonstrably positive impact on the undergraduate satisfaction with their placements education. And they extended beyond the sessions themselves. They had a port of call if they weren't getting their needs met. They were able to take part in ward rounds, perhaps because they had a mission, they had a focus of their participation by finding cases. I think they serve an excellent first step towards opening up learning opportunities like that in what can be quite a busy environment. I do feel they're implementable in most acute medical environments, at least in the ones that I've worked in the past, as they require a junior doctor in order to perform the sessions, a unit that has patients, which I imagine most of them do, and a quiet place to work, and then the 3 hours a week to affect them. And that is essentially a way that I think you don't need sweeping reforms of your acute medical unit structure and teaching in order to get that satisfaction. You just need to be able to set those 2 90-minute sessions aside. And that concludes my presentation. Thank you.
Thank you very much, Michael. That's really interesting. couple of questions coming through about who is doing the sort of 90-minute intervention teaching, and do you think that's important? So, for example, do you think that those targeted sessions done by trainees rather than consultants is better? I'm just thinking from a point of view of feeling less inhibited, you know, being able to explore sort of like your answers without worry. You know, we all know what it's like in the ward round when people bark questions at you and you don't know and you feel terrible. So do you think, who was doing that teaching, and do you think it makes a difference?
There was several people doing the teaching. It was mostly second year foundation doctors up to people who have finished core medical training. I think the majority were clinical teaching fellows, so they did at least have some experience in teaching. And I think that does speak to something that there's junior doctors in every hospital. There's not necessarily teaching fellows and people who are dedicated to teaching in every hospital. But then I don't think that should exclude junior doctors who aren't in teaching fellow roles from taking part, and it should be part of their professional development to take part in teaching to some degree. Whenever I start these sessions and I'm asking the students to present to me, what I always say is, imagine that we're on the ward round. I'm, you know, the consultant who's just arrived, and you are the junior doctor who's just finished a night shift, and then they present as if that was the case. I wonder if a consultant, obviously it depends on the level of teaching experience, I suppose, from the consultant and from whatever junior's taking part in it. I think that's the best way of answering. But I don't feel like it should be a barrier. I think that as long as the junior doctor has been working on acute medical unit for any length of time, they would have an idea of how to structure a presentation and could impart some of that knowledge.
Okay, and there's also a question from a consultant who does teaching medical students, Alex, and he's saying that he finds that confidence, knowledge, engagement and overall satisfaction scores are much higher at the end of placements if consultants take the time to engage with students. What have you done to change your teaching during the COVID crisis, given that most people have stopped small group teaching, face-to-face teaching?
I have been able to take part in acute medical unit teaching during the COVID crisis. Unfortunately, essentially the undergraduate students just at the end of this project essentially weren't attending on the ward anymore. So I haven't been able to take part. I imagine that there's a lot of challenges to teaching on an acute medical environment over a laptop or over a Zoom conversation. So I wouldn't be able to comment, but I'd be interested to hear what anyone else had thoughts on that who might have been taking part in undergraduate teaching.
So someone's made a comment about 10-minute micro teaching, which I think is a brilliant idea and we should all be doing anyway. Just for the last question before we move on, someone's asked about how you demonstrate improved effectiveness of teaching and that satisfaction doesn't translate to improved learning and it's hard to measure. Now, I sort of agree with that, but actually I think if you're engaged and satisfied, then your learning tends to be better. But have you got any quick views on that as a last rather controversial question?
No, that's completely fair. I completely agree. As I say, a limitation of this project is that it did not look at teaching effectiveness, which would be very variable depending on the educator and the student's involvement. But going forward, yes, there would be several ways, such as quantitative testing of the student's knowledge before and after general concepts of acute medicine, or maybe even some kind of practical session where they would be presenting a patient to a consultant or to one of the trainees and then scored in some way. I completely agree that that needs to be something that's looked into, but at least from this project's point of view, I think it shows that we can at least get started down that road.
Yep, really good. Thank you very much, Michael.
No problem.
So that ends all our speaking. Where are we? We've got 5 minutes. So what we would like to do now is have another go at doing the poll. So we are going to pull up the poll questions. If everybody could answer them. Again, we're going to sit in awkward silence while you answer these questions, and then we will have In fact, I might as well just talk while you're answering them, shall I? So next week, we would like you to join us again. Thank you very much to everybody who's joined us today, especially all our international people. That is absolutely brilliant of you to join us, and you are most welcome, and we hope you come back to see us next week. Next week, we're going to be talking about some of the trials associated with COVID, and we're also going to do, which is quite topical, judging by all the questions we had on POCUS this week, how POCUS has been used in COVID and looking after COVID patients. And some would say that it's actually possibly been revolutionary in the places who've actually been able to use it. Sadly, not so much for us. So that's the main thrust of the talks next week. All I can say now is thank you very much to our speakers who have been absolutely brilliant. That we have got CPD accreditation for today, so you can go and claim your CPD points, which is very important at this time when we're struggling to get our learning done. Acute medicine is brilliant, and I know I've stolen that from Bod, but actually I think we've managed to get across such a diverse range of subjects today, and that is the beauty of acute medicine. So if any of you are not acute medics and thinking of doing it, hopefully we've given you a bit of persuasion, and we hope to see you all next week. We're still going with the set. How many more questions have we got? I think that's the last one. So if everybody answers that, thank you very much, everybody, and we will see you all next week. Thank you very much.